Hello all, this is Dr. Kaustubh Mohite, your pediatric pulmonologist. So in the last part, we discussed about the introduction and pathogenesis of community-acquired pneumonia in children. If you haven't watched that video, make sure you go and see that first to get a better understanding of this session. So in this session, let's move on ahead with the further subsections. So let's start with a case-based scenario. A 3-year-old child is presented with rhinorrhea, which is followed by cough with fever and myalgia and with acute onset breathlessness. You see the child is not very sick looking, has mild fever of around 100, is mildly tachypneic for age, maintaining saturations on room air. On examination, you find that there is some amount of tachypnea present, air entry is bilaterally equal, however, there is bilateral expiratory wheeze heard. This is the X-ray of the child. As you can see, there is bilateral perihilar infiltrates. You do the CBC as well as CRP, which is more or less normal. You take the nasal swab and send for viral PCR and it grows rhinovirus. So this is a very typical case of viral community-acquired pneumonia. Next is this 4-year-old girl who has presented with initial complaints of productive cough, which is further associated with fever, lethargy, and acute onset breathlessness. This is a sick-looking child with high-grade fever of 103 degree Fahrenheit, significant tachypnea present, and this child is not maintaining saturations on room air. On respiratory system examination, there is air entry which is decreased in the right supramammary region. Bronchial breath sounds are heard in the same area as well as crepitations are significantly heard. And this is the X-ray. If you look closely, the zoom section, you can see those air bronchogram seen in the right upper lobe. You do the CBC, which is showing significant increased leukocyte count with neutrophilic predominance. CRP is also elevated. You send the sputum for gram staining as well as culture, which grows a gram-positive cocci, and streptococcus pneumonia is being confirmed. This is a typical case of bacterial community-acquired pneumonia. Further, this is an 8-year-old male child. This child presents first with fever and fatigue, followed by sore throat, has some rash generalized present over his body, and finally has a non-productive cough at the time of presentation. You see this very typical generalized erythematous maculopapular rash present. This child also has a fever, is tachypneic, saturation maintaining around 92 to 94% on room air. On respiratory system examination, you hear bilateral wheeze in this child. And this is the chest X-ray. You can see very typical diffuse bilateral infiltrates in this child. You do a CBC, which is more or less normal. CRP is, however, elevated. This child has positive Mycoplasma IgM antibodies and hence is a very typical case of atypical bacterial community-acquired pneumonia. So if we compare the last 3 cases, what clues we could have got just on history and examination to find what could be the etiology? So a bacterial pneumonia comes which is abrupt in onset, the child is really sick looking, has moderate to severe respiratory distress. All the auscultatory findings are focal in origin and shows elevated total leukocyte count as well as acute phase reactants. An atypical bacterial pneumonia comes which is seen more commonly in more than 5 years of age, has an abrupt onset, is associated with non-pulmonary manifestations. A very distinct feature that is seen is that the fever, however, is seen first, which is followed by a non-productive cough. And on examination, you do get wheezing heard bilaterally. A viral, however, is a gradual onset pneumonia. The child is not very sick looking, has preceding upper airway symptoms, and the findings that you get on auscultation are usually diffuse. So if you go across the commonest organisms causing community-acquired pneumonia as the age advances, you see that there are very typical organisms which cause pneumonia in the newborns as compared to the further pediatric age groups. Very important to observe is that newborns is the only age group in which you see gram-negative organisms which is predominantly seen. Otherwise, as the child progresses, the most common organism being virus, followed by gram-positive organism. So you can see that gram-negative as well as gram-positive organism could be seen in equal prevalence in the newborns. However, as a child grows up, Gram-positive is significantly higher in number. On clinical evaluation, we look for general appearance. You see the consciousness, the ability to feed, ability to vocalize, and whether there is any cyanosis present or not. Fever is a variable sign, however, it may be the only sign which is seen in occult pneumonia. Tachypnea is the most sensitive as well as specific sign, however, it should be evaluated as per the age of a child. Finally, the respiratory distress, which involves nasal flaring, retraction, in infancy apnea, as well as altered mental status. Based on the past 4 criteria, you could grade the pneumonia as mild as well as severe pneumonia. Next comes is radiology. There are specific indications when to do an X-ray in a case of community acquired pneumonia. It involves severe disease, when you want to confirm or exclude the diagnosis when clinical findings are inconclusive, when the child is hospitalized, when there is recurrence of pneumonia, as well as you feel that there is some complication involved. However, when you do an X-ray, things that you should be remembered is that the radiological findings are poor indicators of the etiological diagnosis. However, they just give you a very subtle hint towards what could be the etiological organism. The radiological findings always lag behind clinical features. There could be an inter-observer variation. A radiological interpretation may be influenced by the clinical information that you provide to the radiologist. So there are very few subtle etiological clues from the radiology or from the X-ray that you could get in order to evaluate the cause of pneumonia. For example, if you see a well-circumscribed border of consolidatory patch, a segmental consolidation as well as a lobar pneumonia, it hints towards bacterial origin of pneumonia. In case of complications, as in nematocele, an empyema or an effusion or a necrotizing pneumonia, very much hints towards a bacterial origin. Later, if you see any bronchopneumonic pattern or any patchy infiltrates, it hints towards a typical bacterial cause of community acquired pneumonia. Finally, patchy bilateral infiltrates, peribronchial infiltrates, as well as hyperinflation hints towards viral cause of pneumonia. If you can see in the past 2 slides, it is very difficult to differentiate between atypical and viral cause just based on X-rays. Further, for microbiological diagnosis, you do blood investigations to look for bacteremia, whether to see whether it is progressing towards any complication. And once you have a diagnosis, it increases your clinical efficacy as well as it reduces the cost of treatment. Sputum examination gives you a better etiological diagnosis. However, it is not possible in less than 5 years of age. We should remember that an appropriate sample is the one in which you get less than 10 epithelial cells and more than 25 polymorphonuclear leukocytes, along with whichever organism which is isolated. Pleural fluid examination requires a thoracocentesis to get the sample and hence is an invasive procedure. Also, it should be ideally done before you administer IV antibiotics. Finally comes the PCR-based test, which gives us a rapid diagnosis, which can test for various bacteria, viruses, as well as atypical organisms. However, the major drawback is that it cannot differentiate between an acute infection and a past colonization. Serology helps in giving us an etiological diagnosis of a very specific organism. In order to get a serological test, we should have a very high index of clinical suspicion and hence is used mainly for atypical bacteria. Bronchoalveolar lavage requires bronchoscopy to get the sample. This is the one which gives a very specific diagnosis. And finally, lung biopsy, which could be either CT guided, USG guided, or EBUS guided, gives the most definitive diagnosis, but is the most invasive and needs procedural expertise. So that's it for this session. Next session will be focused towards treatment of various community acquired pneumonias. Thank you.